It is now my pleasure to introduce MHA's President and CEO, Paul Gionfriddo, who's a great statesman and advocate for his son Tim and for everyone with mental health conditions. As policymakers consider additional changes to meet the country's needs during the pandemic, Paul makes the case that mental health care must be treated as part of our overall healthcare system, and based on MHA screening data, that these investments are urgently needed to address increases in anxiety, depression, psychosis, and suicidality, especially for people who are Black, Indigenous, or other races. Paul?
Hi, everybody. Welcome to our 2020 Policy Institute. I'm sorry we're not able to do it in person this year, but it's good that we're able to get together, and I'm so glad that so many of you have decided to participate with us today. You know, for us, this is the first of 4 days this week at Mental Health America that we're going to be doing a number of things, but to me, the work that we're doing today is really essential as we lead into our annual conference week here. And that's because so much really is dependent on policy. And while we'll be focusing today specifically on early identification and intervention, and specifically on what's happening to our children and what we can do for our children, the reality is that this entire world in which we're living right now, this entire world of mental health services and supports in particular, is heavily influenced by the policy decisions that our leaders make. And those decisions will be heavily influenced by the information we provide to them, both in terms of data, in terms of stories, and in terms generally of the recommendations that we can make that they should carry forward, moving forward. Now, when the pandemic hit about 6 months ago, we made a decision to take our online mental health screening program. It's been in operation since 2014, and to use it to do real-time monitoring of the impact of the pandemic on the mental health of the population. And so starting in March, we began to provide information about what screeners we were seeing and what screening tools they were using. At first, we saw anxiety numbers going up. Later on, we saw depression screening numbers going up. Still later on, we began to see our psychosis screening numbers going up. And we wanted to understand what that all meant and what we could do about it. Well, you can't understand what it all meant until you think about how truly dramatic this particular wave of the pandemic has been. As of July, from March, we have seen in excess of more than 250,000 people screening positive or moderate to severe for either anxiety or depression since the start of the pandemic. That's 250,000 more people who would have screened positive before the start of the pandemic by using the baselines that we had from November to January. It's really an extraordinary number when you think about it. And one of the equally extraordinary and scary numbers that we've seen are the 90,000 people who, in taking that depression screen, have told us that they have thoughts of suicide or self-harm on more than half the days of the week. 90,000 people, 30,000 in July alone. To put that in some context, we were seeing about 4,000 people a month who had those kinds of thoughts in January and in February. And to see that number, which was very similar to the kinds of suicidal experiences we've had with losing 45,000 to 50,000 people every year from suicide as a baseline, to see that number increase so dramatically really causes us to worry. So we've looked at those data and looked at who, for example, is feeling the deepest effects of this pandemic. And we found two populations in particular that really give us a lot of concern. In the Black population, for example, we're seeing more frequent suicidal and self-harm thinking than we're seeing in any other population. Not that Blacks are necessarily experiencing depression more frequently, they're just experiencing that particular aspect of it more frequently. And it's young people, the 11 to 17-year-olds, who are really feeling the effects of this pandemic the greatest. While 1/3 of people in my age group report suicidal or self-harm thinking on more than half the days of the week. It's more than half of the young people who screen for depression. And it's 90% of the young people screening for depression who screen at positive, moderate to severe for depression when they take that screen. So we have to do something about this. There are things we can do at Mental Health America programmatically by ourselves, and there are things we can do programmatically in association with partners and others. But really, if we're going to make changes, they have to be at the policy level, because it's policy that's influencing thinking these days. It's not the ideas and thinking of people that's influencing policy so much. So we have to use the policy levers we have to improve early identification of kids, to understand as they return to school that we need to be providing mental health services to each and every one of them. We need to improve our special education services for those who are in serious need of emotional and mental health support. We need to make certain that we have provided adequate resources and funding across communities through behavioral health block grants at the federal level to make sure that we paid for all the services people need, even when they are at the earliest stages of experiencing serious mental health conditions. And we need to make sure that we're doing this work systematically, that we're doing it throughout the nation, and that we're doing it effectively by learning from those people who have piloted prevention strategies and early identification strategies, who have piloted educational strategies to improve circumstances there for people who have been doing the good work and now can set examples for the rest of us of how to continue to do this good work. So I hope you're looking forward to the remainder of the day. I know I am. And I hope you're looking forward to the opportunities we're going to have to hear from true experts throughout the course of the day in all of these areas of prevention and early identification, with particular emphasis on kids and kids of color that we'll be talking about. But what I want to do first is to turn things over to Maddy Reinert at Mental Health America. It's Maddy who's been responsible for pulling so much of these data together. And it's Maddy now who, along with Caren Howard, is going to be able to take and answer any questions you may have if you want to dive more deeply into the data or into the implications of these data we've been gathering for public policy moving forward. Enjoy the rest of the day.
Thank you, Paul, and welcome, Maddy. Maddy is MHA's Manager of Population Health, and her primary role at MHA is to manage our largest program, the screenings. At this time, Maddy will answer questions that come in from the chat, so please send your questions in. Maddy, from the 2020 screening overview that you and Teresa released last week, it is clear that several trends have emerged among young people, some of which Paul discussed. But young people who make up a majority of people screening, up to 2/3 of screeners, are between the ages of 11 to 24 years old. Can you discuss some of the high-level trends that you're seeing in the data, especially those that relate to Black, Indigenous, people of color, and lesbian, gay, bisexual, transgender, and queer folks?
Yeah, absolutely. So thank you, Caren and Paul, for that introduction. As Paul mentioned, we are seeing 11 to 17-year-olds screen positive or moderate to severe at higher rates than any other age group. So in July 2020, 83% of 11 to 17-year-olds who took an anxiety screen scored with moderate to severe symptoms of anxiety, and 91% who took a depression screen scored with moderate to severe symptoms of depression. And with those increases in screening numbers that we've seen, that comes to nearly 44,000 youth in July alone who were screening at risk for moderate to severe anxiety or depression. And 11 to 17-year-olds report suicidal ideation at the highest rates of any age group, with 49% of 11 to 17-year-olds reporting that they were experiencing serious thoughts of suicide more than half or nearly every day of the previous 2 weeks. And the data shows us that this growing mental health crisis is not affecting everyone equally, right? So it's affecting Black, Indigenous, and people of color more. So we've seen that Native American or American Indian youth and youth who identify as more than one race are screening more at risk for mental health conditions than youth who identify with any other racial or ethnic group. And we've seen that BIPOC communities have also had the largest increases over time during COVID in depression, anxiety, and suicidal ideation. So in particular, Black or African American screeners had the highest average percent change over time for both anxiety and depression. And Native American or American Indian screeners had the highest average percent change over time for suicidal ideation. And then for LGBTQ plus youth, for both depression and anxiety, the rate of LGBTQ youth scoring with moderate to severe symptoms throughout COVID-19 has actually remained about the same. So LGBTQ youth screen positive for mental health conditions on MHA screening at higher rates than non-LGBTQ plus youth and adults. And across January through July 2020, about 87 to 88% of LGBTQ plus youth who took the anxiety screen scored for moderate to severe anxiety, and around 95% who took the depression screen scored for moderate to severe depression. So the fact that those rates haven't changed also gives us important information. So LGBTQ plus youth are already scoring at such high rates and are already experiencing such persistent anxiety and depression that their mental health needs didn't fluctuate as severely as non-LGBTQ youth and adults in response to the pandemic. And so that's a population level assessment. There are certainly LGBTQ plus youth even more at risk, particularly BIPOC LGBTQ youth who experience even more discrimination and trauma at the intersection of race and sexual orientation, and those who may have had to quarantine with unsupportive or even abusive families or have been separated from their safe communities at school. So those are some of the overall trends that we've seen.
Thank you so much. That's so thorough, and you're obviously able to follow the numbers and the data. We had a question come in about the availability of this data at the county or regional level. Are you able to share about how people might be able to find out what's happening in their region?
Yeah, absolutely. So we do collect some of that information through demographic questions. So when someone comes on and takes a screen, they first are met with the screening tool on the first page. And then on the second page, after they complete that, we ask a number of optional demographic questions. So to receive the results of the screening, people don't have to put in that information, but we actually find that a lot of screeners do. And two of those questions are about state and zip code. So if a screener does answer those questions, we are able to break that data down at the state or county or zip code level. And we do offer that data to people who are interested through, in particular, our associate membership program. But if you are interested in receiving that data at that level, you can always email me. It's mreinert@mhanational.org, and we can share that in the chat as well.
Thank you so much, Maddy. I think we have time for just one more question. How does the increase in suicidality during COVID and the higher kind of at risk and severity that we're seeing in the screening results relate to prevention and early intervention, which is the theme of today's meeting?
Yeah, I mean, first, I think the increase in suicide rates and rates of suicidal ideation shows that we need to do more in terms of prevention and early intervention for mental health crises, and shows that while we do need to invest more in crisis services that can address the needs of those who are experiencing a stage 4 mental health crisis, it also does show the urgent need to start investing more in that prevention and early intervention so that we can reverse the trend in suicide and address mental health needs well before they become crises. So the data in particular on suicide and suicidal ideation is important because it shows us where we can really focus that resource allocation and prevention efforts, and it's showing us who's most at risk. So we can see, again, youth are experiencing suicidal ideation at higher rates than any other age group. And people who identified as another race or Native American or American Indian had the highest rates of suicidal ideation. And so that data really helps us figure out where our prevention and early intervention strategies need to be targeted, so we can stop the upward trend of suicide and suicidal ideation. And so it shows us where we can make a big difference.
And so thank you so much for your time, Maddy. And though we're seeing these really concerning trends in our real-time data, we're fortunate to be able to use this data in our advocacy and hope that policymakers are able to take thoughtful action to invest in supports and community-based services for young people. As students are heading back to school, mental health concerns are top of mind. For school started for many last weeks, for some this week, and will continue into next week. There will be school starting. Let's turn it over to our next moderator and panel, Debbie Plotnick, who will moderate a panel on school-based mental health care. Debbie Plotnick is the Vice President of State and Federal Advocacy at MHA and is recognized as a national thought leader on a wide range of topics in behavioral health. She provides leadership for grassroots and legislative advocacy across the MHA affiliate network.